The following podcast is part of a certified educational activity titled What's Around the Corner in Advanced Prostate Cancer? Candid conversations to future-proof your practice for targeted therapies. Access the entire activity and complete the post-test at peerview.com/FQV860. Downloadable slides and practice aids are also available.
Hello, I'm Professor Karim Fizazi, a medical oncologist from Institut Gustave Roussy in Paris, and I'm pleased to be joined today by my colleague, Dr. Elena Castro.
Hi, Karim. I'm Elena Castro. I'm a medical oncologist from Hospital Universitario 12 de Octubre in Madrid, Spain. Very happy to be with you here today.
Excellent. And welcome all to this educational activity, which is entitled, What's Around the Corner in Advanced Prostate Cancer? Candid, hopefully, conversations to future-proof your practice when using targeted therapies. So, our goal today are to first describe clinical evidence as well as ongoing trials for targeted therapies in the management of men with advanced prostate cancer. Also, equip you with strategies to incorporate biomarker testing to guide clinical decision-making, and then provide guidance for developing individualized and patient-centric approaches to incorporate targeted therapies and optimized treatments for men with advanced prostate cancer.
We will cover a lot of information and we'll have some important conversation about how to best care for our patients in this very quickly evolving space.
Excellent. So let's get started then. A disease in motion, the story so far for advanced prostate cancer. So you may think it's an embarrassment of reach, and it's partially the case. Having said that, we don't necessarily have access to all these treatments. But actually, there are various strategies to use these drugs. One clear strategy has been using them earlier in the course of a disease, at least for the AR pathway inhibitor. And this is now all a standard management for men with hormone-sensitive disease in many countries based on evidence. You may also consider using sequencing these agents or combining them. But more and more, we are also trying to personalize treatment, not only based on clinical parameters, but most importantly, on molecular parameters. And indeed, I think the first example for personalized medicine in prostate cancer has been the demonstration in the PROFILE phase 3 trial that a PARP inhibitor called olaparib can improve not only radiographic progression-free survival, but also overall survival in men with BRCA alterations. And this was shown about 5 years now. A second trial could probably fine-tune this data. This is a Triton-3 trial, which clearly showed, I think, that yes, BRCA1 patients benefit, but no, ATM patients do not benefit from treatment. But let's now review whether we should combine PARP inhibitors with AR pathway inhibition. We have AR signaling promoting DNA damage repair, and on the other hand, PARP1 that regulates AR-mediated transcriptional activation. So very strong rationale to combine. And we now have 3 phase 3 trials showing benefit, and we'll go into more details, when combining PARP inhibitors together with ARPs. This includes PROPEL with olaparib, TALAPRO-2 with talazoparib, and MAGNITUDE with niraparib. So before we move to this combination, I'd like to ask you, Elena, what is your standard management and how much do you use PARP inhibitor as a single agent in your practice right now? Do you use them only for BRCA patients or for some other patients? Let's focus first on single agent use.
Yes, for BRCA patients, of course, I try to make sure that they receive a PARP inhibitor at some point during the journey. And the thing is that I become aware that a patient has a BRCA mutation often after more than one line of treatment, because they are referred to us, and sometimes we have not tested. Testing was not implemented when the patient was became a castration resistant. So for BRCA patients, sure. For patients with other alterations such as PALB2 or RAD51, I also consider a PARP inhibitor. For others, such as those with alterations in ATM or TEC2, I may consider other therapies before PARP inhibitors, because the evidence seems to suggest that the benefit is not so clear for these patients, although some patients may benefit, patients with ATM or TEC2 alterations, but I tend to prioritize other treatments for these patients.
Got it. So let's now focus on combination treatments. So let's start with magnitude. So magnitude basically combine niraparib plus abiraterone versus abiraterone alone in patients with CRPC who had not received a previous RP. And the trial was shown to be positive for BRCA patients with a hazard ratio of about 0.5. So let's move now to a second trial combining a PARP inhibitor, this time olaparib, with an AR pathway inhibitor, again abiraterone. So PROPEL, which is the name of the trial, actually accrued patients with and without HR alterations, and it was mainly aimed at looking at the benefit of this combination for, let's call them, all-comer patients. As you well know, our PFS was significantly improved with a hazard ratio of 0.66 favoring the combination arm. And clearly, patients with BRCA alteration benefited more than others, with a hazard ratio of approximately 0.2, which is, I think, impressive. Overall survival was reported later on, and actually the hazard ratio is 0.81, with a non-significant benefit in the all-comer population. And again, we see a quite clear discrepancy between what's achieved for patients with BRCA alteration and a hazard ratio for overall survival of 0.29, which really is fantastic, was impressive. While for patients without those alterations or those, say, all-comers, regardless of whether they had those alterations, yes or no, the hazard ratio is more modest, again, 0.81. So what is your take on from PROPEL? What do you think?
As you explained, I think PROPEL illustrate very nicely that there is a hierarchy, a very clear hierarchy in the benefit from these PARP inhibitors in combination with ARPs, with a very clear benefit for BRCA that is greater than for HRR, which is greater than for a non-selected population, and greater than in patients without HRR defects. The benefit that we see for patients with BRCA alterations is huge. I think it confirms that these patients should be offered a PARP inhibitor at some point. And in this study, we didn't learn whether patients were carrier or not, had HRR alterations or not up front. It was a retrospective analysis, but I think with the results of this study, it supports that we screen our patients and we identify who are the ones with alterations, because the benefit seems to be quite different depending on their BRCA or HRR status.
All right. Let's move to the third trial, which is still preliminary as we speak, TALAPRO-2. This time it assessed randomly talazoparib plus enzalutamide, not abiraterone, again in men with mCRPC with no prior AR pathway inhibitors. Primary endpoint was our PFS, radiographic progression-free survival. Again, the trial is positive. Hazard ratio is approximately 0.6, which is significant. Again, we see a clearer benefit in men with BRCA alterations, but perhaps also for men not only with BRCA2, but also BRCA1 and CDK12, as you said before, not for patients with other alterations such as CHEK2, for example. So based on this available data, again, what is your perception from this trial?
Well, I think TALAPRO-2 supports what we just commented for PROPEL, this hierarchy in the benefit. This should prompt further investigation that trying to understand what happens in this group in which we don't identify HRR defects. Who are those patients that may benefit? What is behind that response to the PARP inhibitors? Because I guess there are many things we still don't know, and we can really learn a lot from understanding this group of patients.
All right. Let's move to another targeted agent which showed again benefit, and this is obviously lutetium PSMA. Lutetium PSMA is actually a targeted agent because it's a ligand binded to a radioisotope, lutetium. The ligand finds the protein PSMA at the surface of cancer cells, and the radioisotope is being internalized and hopefully irradiates them and kills them. So this is really the concept of this treatment. Vision was really the first phase 3 trial showing clear, I think, efficacy in the setting with not only radiographic progression-free survival benefit, approximately 60% reduction in the risk of progression or death, but also benefit in overall survival with a reduction of approximately 40%, which is not very often seen in oncology when it comes to overall survival.
Let's see very briefly how these advances have been implemented in the clinical guidelines that we use in our daily practice. So the European Association of Urology has echoed these new advances and make very strong recommendations about the need for testing our patients for both the use of targeted therapies, but also to identify patients with germline alterations. Don't forget that prostate cancer is one of the most inheritable human tumors. These EAU guidelines have also entered into details regarding the different agents that are currently available for mCRPC, and also make some recommendations for the sequencing of therapies. The ESMO guidelines were updated in 2023 to include the use of olaparib for the patients with BRCA alterations, and for those patients who had already progressed to an RP and to a line of chemotherapy at taxane, there was the possibility of using cabazitaxel that the CAR trial demonstrated to be superior to a second RP, but also the guidelines were updated to include a recommendation for the use of lutetium. These guidelines are now being updated in 2024 to include all the novelties that have occurred in the last couple of years. Karim, you are the chair of these guidelines. What are going to be the main changes in these guidelines?
Thanks, Elena. I guess, the main change, as you said, is that we now have many treatments to discuss for the patients with advanced prostate cancer, not only including drugs. We are medical oncologists, but also local treatments. Radiation oncologists are being more and more involved. but also the local treatments by urologists, radiopharms by nuclear medicine docs, etc., etc. So this time we decided that 5 or 6 people would not be enough to write the guidelines for advanced disease, and that we actually needed many more people, about 30 authors from all these different specialties and from all around the globe, also to reflect what's what are our practices depending on our countries. So I think it's going to be a much richer and probably a more relevant guidelines. Also, our plan is really to update these guidelines probably on a yearly basis. Things are going so fast that as soon as a guideline is out, it's almost outdated. So we really need to be very flexible to update them rapidly, doing short guidelines so that people can really focus on what's new. So this is really the philosophy for ESMO guidelines.
And the truth is that there are many things that cannot be included in the guidelines as recommendations to do or not to do because we don't have enough evidence in one direction or the other. And for that, we are fortunate to have APCCC, where experts from around the globe discuss these gray areas in the management of advanced disease. And at APCCC, we discussed, for instance, how should we manage patients that are positive on PET PSMA only, but we don't see metastatic disease on conventional imaging. How who are the patients with HRR alterations that benefit the most? Should we use these PARP inhibitors alone or in combination? If a patient is progressing to an RP, can we just add the PARP inhibitor? Do we need to switch? Do we stop the RP? And I think it was, to me at least, it was a very enriching discussions about different topics. I don't know which one was your favorite, Karim.
I don't know if I had a real favorite, but I agree with you. I think guidelines and consensus meeting, so APCC, are very complementary. Guidelines are telling us what we know, and consensus meeting are addressing situations where we don't know what to do because there's no strong evidence. So you're right. I mean, I am learning every time I'm attending the APCC because we can really share opinions, confront them, and probably be better as prostate cancer doctors, just because we're learning from others. We're going to try to address what's on the horizon for targeted therapies. And I think a lot is coming or just came to us very recently. For example, the P3 data were just released at the ESMO meeting in September 2024. P3 is the second phase 3 trial addressing the question as to whether we should combine an AR pathway inhibitor with a bone targeting agent called radium-223. And I'm saying it's the second because the first one, ERA-223, combined abiraterone and radium-223 and actually failed to show a benefit, unfortunately, with a clear excess in fractures in the experimental arm. So taking this into account, the investigators and the leaders from the P3 trial, which addressed the same question with enzalutamide and radium, amended their protocol to make bone protecting agent mandatory in their trial. We've learned, I think, quite a lot from the trial. Number one, bone protecting agent work. The incidence of fracture went down dramatically after the amendment from about 50% and 25% respectively in the two arms without bone protecting agent to almost 0% after these bone protecting agents were implemented. So I think this is a very clear message to all of us, regardless of the trial, for our practice. We should use these agents. Second, for the first time, a phase 3 trial testing combination treatment in mCRPC shows not only progression-free survival benefit, but also clear overall survival benefit, favoring the experimental arm. And I think, to me, this is practice changing, at least for men who were treated with ADT alone before they developed mCRPC. So let's move to another recent example. This is PSMA4, testing this time lutetium PSMA in men with mCRPC who have not received or not received yet docetaxel chemotherapy. So, but they had received an AR pathway inhibitor. So the trial tested either lutetium PSMA or second RP, typically enzalutamide after abiraterone. The trial is positive by its primary endpoint of radiographic progression-free survival, very clear benefit, with approximately a 60% reduction in the risk of progression or death, favoring lutetium PSMA. This came together with benefit in terms of time to deterioration of quality of life, time to pain deterioration, time to skeletal-related events, and overall survival, I think, is not easy to assess in this particular trial simply because 84% of patients from the control arm actually crossed over to lutetium PSMA and actually crossed over rapidly because they progressed after 5 to 6 months. So we were really comparing lutetium PSMA today versus lutetium PSMA in 6 months' time. But now let me move to a third example, which is more experimental at the moment, and that is about AKT inhibition, especially in men with PTEN loss. We know, you and I, that approximately 20-25% of all the patients with prostate cancer actually have cancers with PTEN loss, and this is actually associated with aggressive behavior of the cancer. We also know from lab experiments that in these men, we should probably target both the androgen receptor pathway and the AKT PI3 kinase pathway at the same time to get a greater benefit. And this was, I think, beautifully and very elegantly shown in the randomized phase 2 trial conducted by Johan de Bono, showing that combining an AKT inhibitor with abiraterone works better than abiraterone alone in patients with PTEN loss, but not necessarily in others. But right now, we have other data combined with docetaxel and another AKT inhibitor called capivasertib, suggesting that the benefit might be true for all comers, and another trial combined with enzalutamide with more unclear data. What is your current take about all these small randomized trials that we now have regarding AKT inhibition at the moment?
Yeah, it is such a clear target, right? And it seems that it's so evident that if we will be able to target this properly, there should be a benefit. But it is resisting to be targeted, and perhaps the key here is also patient selection, that we may not be using the right biomarker. In the potential trial, we saw a difference by using immunohistochemistry or next generation sequencing. And I believe there may be something about this. And when we don't see a clear benefit in the ipatasertib in overall survival as we would like to, but there are still other studies targeting this pathway, and I guess that eventually we will be able to see a benefit.
Absolutely. So, and actually, we had the data from the Capitello 281 phase 3 trial in metastatic hormone-sensitive disease and PTEN loss, which are pending. Hopefully, we'll see the first data maybe next year.
Most of the new treatments that are available for advanced prostate cancer are targeted therapies, the ones we currently have and many of the ones that are currently under development. And we need to be able to identify the presence of that target if we want to select the right candidate for a treatment, or said in another way, if we want to choose the right therapy for our patient. So with the use of PARP inhibitors in monotherapy, it was very clear that patients with HRR alterations were the ones that benefited from these therapies, and particularly patients with some alterations, BRCA1, BRCA2, PALB2, etc. But the majority of our patients don't have those alterations, and different studies trying to expand the benefit of this PARP inhibitor to those patients without HRR defects. And indeed, we see some benefit from the combination of ARPs and PARPs for patients without those alterations. And the EMA has approved these combinations for all patients with mCRPC, and the approval doesn't require genomic testing, whilst the FDA has been more restrictive and has approved these combinations only for patients with BRCA or HRR defects, depending on the agents. So the question, at least in Europe, is whether to test or not to test. And we know that the benefit is different depending on the presence or not of these alterations. But on the other hand, and the side effects will be very similar to all patients with and without these defects. So this is something that we have to find a balance between the side effects and the potential benefits. But we also have another difficulty, that is the access to this testing, and we need to ensure that all patients could have good access to testing. And unfortunately, this access and reimbursement of testing is very different in the different regions, and I believe that really conditionates what the clinicians decide to do or what they can offer. Karim, what is your experience or your thoughts on that?
But I think more and more we have data supporting testing. You just mentioned the data about PARP inhibitors and how different they work depending on what we find of the testing. But there are new examples coming or probably coming soon using, for example, assessing AR mutations. We spoke about PTEN loss, etc., PSMA expression, etc., etc. So I think more and more we need perhaps to test all the patients.
So ESMO currently recommends that at least BRCA1 and BRCA2 is tested for all patients with advanced prostate cancer. The evidence of the benefit for PALB2 patients is limited just because of the number of patients. This is a rare alteration in prostate cancer. And currently, we don't have AKT inhibitors approved in this scenario, but perhaps some of the trials that are currently ongoing finally demonstrate this benefit, and we are able to use it. What I think is that perhaps once we have more therapy approved, it will be easier for all of us actually to implement this in our routine practice, or if finally we can use it for MHSPC, if there is a benefit. My dream is that the pathologist send me the report of the tumor with the Gleason, everything, and then the genomic alterations. We need to continue characterizing the tumor of our patients, and not only for that, also for radioligands. We need to be able to select, to identify the patients that have that target and are more likely to benefit from these therapies. So, Karim, do you think we will stop offering treatment for all patients, all comers, and we are finally into the era of this precision oncology? Or do you think some of the trials will put us away from this path, and we will stop doing this because of the struggle?
So I really believe that this is, if not the near future, or almost the present.
I totally agree. I think this is unstoppable. It will take some time, and perhaps we are moving not as fast as we would like to, but I think this is definitely the way forward.
Moving away from a one-size-fits-all model, how do we translate benefits to individual patients with mCRPC? And to address this question, this is a case of a typical gentleman with metastatic prostate cancer. He's now 72-year-old. He has mild fatigue, some previous history. By the way, not only individual and personal, but also familial history of breast cancer. His sister, who was diagnosed with the disease when she was about 60. And this patient had prostate cancer, Gleason 9, aggressive one, with initially no bone metastasis and a PSA quite high, 28. So he was treated with various treatments, including ADT, and is now progressing while on ADT alone. And actually, following your recommendation, he could benefit from an NGS testing showing actually a germline BRCA2 mutation. The patient is fit, again, castration-resistant, ADT alone until now. What's next? How would you typically treat such a gentleman?
Well, the data we have suggests that what benefits these patients the most is treatment with a PARP inhibitor. Because this patient has not received an ARPI previously, I will give it in combination with an ARPI. And we also have some data from the BRCA study that also suggests that indeed this combination may be better than the PARP inhibitor in monotherapy. So I will go for a combination of a PARP and an ARPI.
That makes sense. In terms of tolerance for 72-year-old gentleman, do you think he will manage to carry on with a combination?
My experience is good. So, well, there will be some side effects from both drugs, of course, but perhaps more concerning from the PARP inhibitor. We may see some anemia, depending on the compound we decide to use. We may see more thrombocytopenia or neutropenia. There may be some gastrointestinal discomfort in form of nausea and perhaps some fatigue. But in my experience, this is all manageable. We just need to monitor the patient and be careful. But well, majority of our patients are more or less this age, or at least my patients, and I think this combination can be tolerated.
All right. So let's assume that he's on this combination of an AR pathway inhibitor and a PARP inhibitor. It works. This is a BRCA2 alterations for maybe a year or year and a half, especially if this is a deletion, is most likely to benefit long. But of course, this is not curable. So what would you do next after a patient develops cancer progression on this doublet therapy?
Yes, after progression to a PARP inhibitor, we don't really know how to manage these patients because the data we have suggests that the response to docetaxel or cabazitaxel is not very good. And we don't have much evidence on response to radium-223 or lutetium. So we can use any of these, but expecting a not very good response. And well, I would like to try something new for these patients. And I don't know if after a long treatment with an RP, perhaps this patient may have AR mutations or amplifications, and you think we can try a new agent, one of these new therapies being developed to target AR?
Yeah, I think so. I think it would be indeed good to know his NGS status post progression. There are indeed some acquired alterations from the androgen receptor, for example. Approximately 20% of these men develop mutations, and the recent data point to the direction of a clear benefit from third generation AR targeting in patients with mutations versus those without mutations. Of course, this requires validations from phase 3, and the phase 3s are ongoing with various compounds. But I think we are heading towards this direction, again, for these 20-25% of men with AR mutations. Another important biomarker I would like to know about this gentleman is obviously his MSI status. This is only 2 to 3% of all the patients with MCRPC, but if an MSI high status is being detected, to me it's a clear signal that we should treat this gentleman with immunotherapy, a checkpoint inhibitor. And this was again confirmed recently at the ESMO meeting with a combination of PD-1 and CTLA-4 treatment. So that is really something I'd like to ask all biologists in those situations. Finally, you mentioned PSMA, and there are emerging data suggesting that patients with BRCA alterations may actually benefit even greater from PSMA targeting. Again, this requires confirmation, but having a patient with BRCA alteration, to me, would not be a good reason not using PSMA targeting. I agree with you. I would keep that for right now for after a PARP inhibitor, but I would definitely consider that. And of course, we are learning. Every year we're learning new findings about all these patients, which is great.
Thank you very much for joining us today. I think we have had a very nice summary of the evidence that support the use of targeted approaches for the treatment of our patients. And we've gone through the guidelines, we've discussed some of the caveats that we currently have for this treatment, and I think we've learned effective strategies to integrate these new therapies in clinical practice. So thank you, Karim, for inviting me to join you today.
Thank you very much, Elena. Great to be here, really. So please, to all, remember to download the practice aids associated with this educational activity. There's a resource, hopefully, for you, your staff, your patients, maybe. Thanks again, and we hope you found this activity informative and useful for your practice. Thank you.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education, and by the European Board for Accreditation of Continuing Education for Health Professionals. This activity is supported by an independent educational grant from AstraZeneca. To access all materials for this activity, visit peerview.com/FQV860.